I am excited to welcome you all to the National Critical Access Hospital Quality Inventory and Assessment Kickoff event. Before we get started, I just wanted to note that this is a call for state flex programs and subcontractors only. And so if you're on the call and you are from a critical access hospital, this call is not for you. We just ask that you jump off the call and follow up with your state flex program if you have questions. Otherwise, they'll be reaching out with you with more information soon. So with that, I'm actually going to pass it over to Dr. Dillon, the Chief Medical Officer from the Federal Office of Rural Health Policy, to get us started, and then it'll come back to me. So Dr. Dillon?
Yeah, good morning. Thanks. No, good afternoon. It's been a long day already. Great to see you all. And it's, I can't tell you how exciting it is to be kicking off this process. It's been long in the planning, and it's been great to work with Megan and the folks at the Flex Monitoring team to have the support of TASC and putting on the webinar. And then also my wonderful new colleagues here at the Federal Office of Rural Health Policy. So as Megan said, my name is Kristen Dillon. I'm arrived now 6 months at the Federal Office of Rural Health Policy as the Chief Medical Officer. So that position has been reinstituted, and I've had just a wonderful warm welcome from the folks here in the office. And also from all of our external partners and stakeholders. So thank you for that. I have 25 years experience still going as a practicing physician in rural communities. I know what it's like to work in rural health clinics and critical access hospitals and federally qualified health centers. I know the challenges you face. I know the incredible assets that your communities and the hospitals you work with have. And also the creativity that can be brought to solving some of these issues. I think if I could help you all make a pitch for why are we doing this? Why are we doing this now? We just want to ensure that the work that we're doing as we go into a new cycle of Flex and the next iteration, the next version of MBQIP is to ensure that we are making meaningful improvements in the quality of healthcare that rural residents in this country receive, and that we're making optimal use of your services as state offices and other Flex grantees, and of the hospitals that you work with. I'm very aware in healthcare that most of the time when you're doing one thing, it means you're not doing something else, and we want to just do everything we can to make the best use of everyone's time and effort. And social capital, given the voluntary nature of so much of this work. The other thing that this tool will really help us with is we are endlessly getting questions about the services available in rural hospitals and the places where there's gaps. We can tell to some degree because of our colleagues at UNC and the work they do when a hospital's closed. But other than knowing who's closed and who's open, knowing who has a birth unit, who has PT, who has pulmonary rehab, who has an infusion center or cancer treatment, all of those those are information that are not readily available, that are not available from any other federal or public source that we can achieve. So we are working with you all to hopefully start to pull that information together, because the work we can do in supporting rural health, supporting policymakers will be so much more powerful if we can have an accurate picture of the little more nuance around what's happening in the critical access hospitals across our country. So thank you. We understand this is more work, this is more effort. I know what it's like to try to persuade people who don't have to follow you to do what you're asking. And I hope these words will help you to communicate with them the importance of what we're looking for you to do. So thank you very much for the work you do on behalf of rural communities, and I'm going to pass it back to Megan.
Great, thank you, Dr. Dillon. So what we're going to do today is I'm going to jump in to the slides here. Our objectives for today are to learn about the rollout of the National CAH Quality Inventory and Assessment, and I'm going to stop saying all of those words every time and just call it assessment. And then also to discuss questions about the assessment rollout and data. So this is a timeline that hopefully you've seen before. We've been talking to all of you for a long time now. It's been quite the process in developing the assessment over the past little bit over a year. But right now we're entering the national pilot phase, and we call it a national pilot, but as everyone, it's just nationally the first time that we're doing this. And so obviously there will be things that need to change in the future, but we're really excited about what we've developed to this point, and really excited to get into having the assessment open and live as of today. The background here, with funding and support from FORHP, a bunch of Flex partners have collaborated on the development of the assessment. This has been a process, like I said, for over a year. Many organizations have been involved, including FORHP, FMT, Stratus Health, TASC. We've worked with an advisory group to help develop the questions for the assessment. That group included state flex programs and quality subcontractors, as well as CAH quality experts and folks working in CAHs, and others. And so we've had a lot of work and a lot of feedback along the way in developing these. And the plan is to gather information to assess CAH quality improvement infrastructure and to better understand CAH measurement and quality activities across different service lines. And that CAH quality improvement infrastructure, another piece of this was we had the CAH Quality Infrastructure Summit last spring that also brought together experts from across the country to really look at what is CAH quality infrastructure, what does that look like, and how can we start to measure that? And so we'll get to more of that later. The purpose of the assessment, again, you've probably seen these slides from us before as well, but it really looks at 3 different levels of how we can capture information to support quality activities. And so starting at the hospital level, this is being able to provide state and national comparison information for hospitals on all of these different components, that quality infrastructure, different processes that are involved in quality work, quality activity specifically, and measurement across different service lines. So being able to look at how you as a critical access hospital might compare to others nationally and in your state, and what support you might need based on what you have. At a state level, it's really, for all of you on this call, it's being able to provide that timely and accurate information related to CAH quality improvement and quality measurement, and looking at how can this information best improve and inform the work that you're doing. How can this feed into your work plans each year? How can this tell you, wow, I really have a lot of hospitals that have a great need in a certain area, or they're trying to develop a new service line. Who can I look at in my state or in other states to help support this? And so really it's being able to give all of you that information that is in a standardized manner, that's collected, that you don't have to go out begging for this information each time it's needed, or each time someone asks you from your state or wherever for this information. And finally, at the national level, this is about providing that information to help inform the future of MBQIP, like Dr. Dillon was talking about, and also help inform the technical assistance provided to you to be able to support your hospitals. And so the development of this, like I said, it's been a long time coming. The 2 primary objectives really are to gather an inventory of service lines and related quality measures that hospitals are tracking to identify those needs and the trends, and help inform flex initiatives both at the state and the national level. So like I mentioned previously, that advisory group really came together to provide input on what are those things, what are those pieces of information that would be most helpful to have as a state flex program, and how's that going to be able to help support hospitals. And then the second objective is really to assess the implementation of the core elements of CAH quality infrastructure, and that those core elements were what were developed in the CAH Quality Infrastructure Summit. So those elements, and then the criteria to be able to say, how do we actually show that you're doing those elements of core infrastructure and quality? And so those are really the big objectives that will come across through the assessment. So thinking about what are the benefits. So we've touched on this a little bit, but just a little bit more about, how will this be able to help you? And these are just some ideas. And at the end of the call today, we'll be able to have a little bit of discussion about what folks have thought about as far as how they might be able to use this information in their state. But some examples are, you can use, so we'll be collecting service line data. This can help you to identify CAHs to work with on new projects. So if you have hospitals that you'll know who has swing bench and rural health clinics, who has labor and delivery. And you can kind of look at that in connection with other factors as well. Who has swing beds and is using the same EHR, different types of things that are going to be collected. You'll have that information at your fingertips to be able to say, how can I create new projects in my work plan to be able to best support the hospitals in my state in different areas. You'll be able to use the CAH quality infrastructure data to see what the greatest needs are for developing quality infrastructure across your CAHs in your state, so that you can say, wow, they could really use some help doing this, working with their leadership. They could really use some help in their data collection, different areas that they might need to develop a little bit more as far as quality infrastructure in their hospital. You can reference the assessment data before orienting new quality managers. This is something on a previous call, someone said, wow, that would be really great. I could plan this out, print out the information for their hospital as I go in to orient a new quality director and show them this is what's happening at your hospital, or tell them to reference the assessment that someone previously at their facility has filled out. This could be a great resource so that they know what's been going on, where some of their infrastructure needs might be as far as quality, and give them ideas for how they can start working on that or working with you as a state flex program on different initiatives that you're doing. Also using data to create learning collaboratives or cohorts among CAHs with different similarities. So this is, like I mentioned earlier, some folks have the same EHR vendor. You'll be able to know that now. You'll have that information, or the same service line, or combining those two factors to say, wow, or the next one is pairing hospitals with opportunities. So you might say, wow, this hospital has really struggled with their EHR and implementing it and looking at these new MB-QIP measures. Is there a hospital that has successfully used this EHR and been able to do some really cool things with it? And so it's both identifying hospitals that you can pull together in a cohort to address some challenges or some initiatives that you're working on, but also pairing those who've had some success in some areas or already have an existing service line and talking to someone who might be wanting to add that service line. Just a lot of different information that you'll be able to use in different ways. You'll be able to identify other states that have CAHs that have similar goals or opportunities. And so this is something we've seen folks starting to do over the past couple of years, working across states. You may have only one hospital that has labor and delivery in your state, but other states may have some more hospitals or other singular hospitals working on those things. And so being able to know what other states, what their data looks like, how they can be able to work with you on some of these initiatives that you could be planning will be a really great asset for the state, for all of the state flex programs and federally as well. And then finally, be able to prompt conversations with quality contractors for how to best address improvement opportunities. So we know that many states have quality subcontractors, and many of you are here today, but this is perhaps another way to be able to connect the dots and say, wow, it looks like a lot of our hospitals in our state are having challenges with certain areas as far as quality infrastructure. As a subcontractor, can you help me develop a way to work with them on this? And so this is helpful to state flex programs as a whole to be able to look and see how can we advance the quality infrastructure in our hospitals, and how can we help them support the quality improvement as well. And then also thinking about, how does this benefit the critical access hospitals? And so we'll talk a little bit more about this later as well. But thinking through, how do we tell them, this is really important for you, and this is going to help you in the future as well. So CAHs will be able to assess their quality infrastructure. So they'll be able to compare to others in their state and across the country. They'll see, how am I doing in the core elements? How do I compare to those in my state? And perhaps what are areas that I can work on. They'll be able to benchmark and compare themselves, like I said, in infrastructure as well as in other areas to see, do I look like a lot of the other hospitals in our state? Maybe I can work with my state flex program to be paired with another hospital that looks a lot like me that I haven't worked with before. And so being able to just have those benchmarks and comparisons to use. CAHs will be able to work with state flex programs to have these peers within their state and nationally. Again, it's being able to connect hospitals to learn from each other or to work with each other on initiatives. Again, if there's, they share an EHR vendor or service line, opportunities for them to be able to work directly with others and have that paired up instead of having to go out asking others, who else is doing this? How else might I be able to get this done? So just feeding that information at the state level so that folks can get connected. And then hospitals will also receive more targeted technical assistance from their state flex programs. All of you will be able to see, what are the greatest needs across your state? What are hospitals really, what could they use some support in? Whether it's, based on different service lines. Well, we have a lot of hospitals with swing beds now. Maybe we should look into doing something there. Whether you have a lot of very low volume hospitals, you'll have information about ED volume, as well as average daily census. So you'll know who are those really low volume hospitals. Some more information about quality reporting. This is outside of MBQIP. So what else are they looking at and reporting on? What are initiatives that they're interested in at the hospital level, and other key needs and opportunities. And so it's really being able to get the information from the hospitals and be able to feed it back to them and support them in a lot better ways. And so now I'm going to pass it over to my colleague, Maddie, who's going to walk through the different components of the assessment, so that you'll have a better idea of kind of what is all in there, and how you'll be able to, the information that you'll be able to receive at the end.
Thanks, Megan. I just want to echo to what Megan and Dr. Dillon said about how excited we are for this to be launching, and how much we appreciate all of your efforts in this as well. It's been a big undertaking. There's been a lot of work behind the scenes, but we're really excited to have access to all of this information and to give you access to it as well. So just wanted to echo that as well. So like Megan said, I'm going to kind of walk through the different components of the assessment, and give some example questions so that you have an idea of what this looks like for your cause. And starting off, so the assessment itself is kind of in these three different components, or three different areas. So the first is identification of key CAH characteristics. And then we have the assessment of CAH quality infrastructure. Last but not least is the inventory of CAH service lines and related quality measures. So I'll talk through kind of each of these three parts. You can go to the next. So for CAH characteristics, this includes basic CAH characteristics like hospital system membership and information on who contributed to the assessment. As a reminder, we really encourage CAHs to work with a number of different staff members. So this will ask, what are the roles of the folks who contributed to the assessment? We also ask about volumetrics, so average daily census and total ED visits, as well as EHR vendor and how they use their EHR for quality reporting. So this is one example. So this is the hospital system membership question. It says, please describe your hospital system membership. And then they have three options. So they select one of these options for this question. This is another example. So this is, excuse me. So this is one where they fill in the average daily census for inpatient acute care. So they just enter in a number, and some of these questions are set up so that there are limits. So for this one, it's limited to 25 or fewer, since they are a critical access hospital and only have 25 or fewer acute care beds. It'll also give them an error if they accidentally type in something that's not a number, for example. So there's some of those things built into the tool. And then here's another example of a multiple choice question. So which vendor provides your primary inpatient hospital electronic health record system? They have a list of common EHR vendors for critical access hospitals. And then there's also an other option where they would be asked to enter in the name of their EHR vendor. And again, this one is set up so they only select one of these options. So the second part of the assessment is the CAH quality infrastructure piece that we've talked about quite a bit. So as a reminder, these are the 9 core elements of CAH quality infrastructure. There's also a link to that summit report that I think Caroline dropped in the chat as well. But when you see the slides, you can check that out too. But here are the 9 elements. So in the assessment, they will be asked about criteria for each of these 9 elements. And I'll talk about that a little bit more on the next slide. So this is an example element. So the overarching element is collecting meaningful and accurate data. And that is described as applying a multidisciplinary approach to identify key quality metrics, prioritizing complete and accurate data collection. And for each of these 9 elements, there's a number of criteria that basically outline what a CAH should be doing or can be doing to demonstrate that they meet that element. So for this particular element, there's 4 criteria, which are: the organization has a multidisciplinary process for identifying key quality metrics. Leaders identify risks and opportunities based on analyses of key quality metrics. The organization leverages health information technology to support complete and accurate data collection. And the organization collects and documents race, ethnicity, and language, sexual orientation and gender identity, and health-related social needs data. So each of the elements has their own list of criteria that will be basically translated into a question on the assessment so that we can see which of the criteria each hospital is meeting. So I think that example is on the next slide. So this is an example question that was directly pulled from that element. And so it asks, which of the following data does your facility have a standardized process to collect? And this is a select all that apply. So it has an answer for race, ethnicity, and language, sexual orientation and gender identity, health-related social needs, and then there's also a none of the above response option. We can go to the next one. And then this is another example from a different element. So it asks, which of the following standardized methods does your facility use? Select all that apply. And again, they have different options here, as well as a none of the above. I believe most of the questions in the infrastructure section are multiple choice like this, where it's either a select all that apply, or sometimes it's a select, one. And just so that people kind of have the context, we have all of these questions basically map onto the criteria that we've established that go with each of the elements. So you can kind of see how it fits together here, but these are just, again, some examples. I think there's one more. And then this last one says, which of the following statements about strategic planning are true at your facility? Again, it's a select all that apply. And it says CAH quality leaders participate in strategic planning. Quality is a core component or pillar of our strategic plan. QI is reflected in all core components or pillars of our strategic plan. Examples. And a none of the above option for this one as well. So that's a general idea of kind of what those infrastructure questions will look like for your CAHs. And then the last section of the assessment is the inventory section. So this includes service provision, and this is in all domains of the hospital and entities that they own, including swing beds, labor and delivery, behavioral health, and many more. And then we also ask about quality measures by service line and area. And these, again, are outside of MBQIP measures because we already have access to those measures. So we include these for inpatient, outpatient, mental health, specialties, and other services. So this is one example question. And so it says the section asks about the services your hospital provides. Please answer yes or no to this following question. Does your hospital or an entity owned by your hospital provide? And then this one is for hospital outpatient services. So it has on the left a list of the services, and then the columns are yes and no, where basically the respondent is asked to just check yes or no for each service. And each of the sections will look really similar, where it has the list of services. You just select yes or no for each and just go right down the list. And then this is what all of the quality questions will look like. Again, they're broken out by outpatient, inpatient, specialty services, etc. And it asks for the measure OP23 with a brief description, which best describes your hospital's activity. And then they're asked to select one of the options in the dropdown. And so the options are: our hospital submits and actively monitors this measure, our hospital submits this measure but does not actively monitor it, our hospital only actively monitors this measure or one similar, and our hospital does not submit or actively monitor this measure. And in the assessment itself, they'll get a more detailed definition of what we mean by submitting and actively monitoring. So they'll have some examples to reference there. And yeah, they just select one. Also, for these quality measure questions, some of them pertain only to certain services. So for example, psychiatric services, they will only see that question if they had selected that they provide those services in the service line section. And I think I'll pass it back to Megan.
Great. So we went through that really quickly and gave you kind of an overview of the different sections. A couple of reasons for that. We don't feel the need to walk you through all of the questions, but wanted to give you an idea. You all should have also received earlier today, Laura from FORHP sent out an email, and that also again included information. It had attachments that have all of the questions to the assessment, so you have access to that, as well as a detailed instruction sheet for your hospitals that again has all of the questions, and then instructions for how to respond to each of those questions. And so that information is at your fingertips. If you don't have that, please feel free to reach out to me after the call today. That information is also posted on TASC's website. And so that is information that you should be able to access to see all of the information on the assessment. There was one question that came up about asking about, I believe it was swing bed volume, and I can address that briefly here. We'll have more time at the end for questions and discussion too. We really did go through the assessment and tried to make it as efficient as possible. We asked about volume for ED and inpatient. Obviously, swing bed volume is really important. Right now, we don't have a great accurate count of who is providing swing bed care, and so that's one thing that's asked in the service line provision portion of the assessment. And so there are we have a whole list of ideas for different questions in the future as soon as we have some of the most basic things right now. And so we do obviously recognize that swing beds are really important for a lot of critical access hospitals, but at this time that did not make the cut for the assessment as far as the volume questions. And we can get into any more questions that come up. But now I want to go through a little bit about the logistics. So, you've seen a little bit about kind of the background for the assessment. You've seen a preview of some of the information in the assessment and what that might look like for your hospital. And so now getting into the logistics of how is it all working. We'll start at the end a little bit. So we are going to be really excited to get all of this information to you as soon as possible. So after the assessment is completed, we will start the analyses of that. And in early 2024, state flex programs will receive the data from the assessment for their states. Excuse me. What you'll receive, you'll get a state level report that'll be in a PDF. This will be really similar to like the FMT annual reports. This will be a state level report that summarizes some of the key data from the assessment. And that will also have a national comparison. So that'll be kind of a broad look at how your state compares to the rest of the CAHs across the country. And then you'll also receive a spreadsheet with the full CAH level data from the assessment. This will be a lot of information. We're working on the best ways to organize this for you. And so we're breaking it up into sections. And you'll also have with that spreadsheet a tool that will help distill some of that information and present it in a way that's a lot easier to summarize or a little bit searchable, similar to the antibiotic stewardship tool that folks have used in the past. And so we're really have been working for a long time on getting this information to you in the best ways. And we'll always take feedback on that for future iterations, but you will be getting a state level report as well as a spreadsheet with all of the data that you can use in whatever ways you want. And we'll be getting that out in early 2024. We recognize that you will all be in the throes of writing your NOFO starting around December. And so we'll get this information to you as soon as possible. Unfortunately, there's no guarantee that we will get that to you before your NOFO is due, but we will get it to you as soon as we feasibly can. So receiving the information, the assessment is open as of right now. So like I mentioned, state flex programs, all the folks on the distribution list should have received an email from Laura at FORHP this morning. In that email, there is a template email for you that you can use to reach out to your hospitals. If you do alter the template, please make sure there's a lot of detailed information on there about where the link to the live assessment, as well as some of the other resources they could use. Like I said, those questions and the instructions that would be great for you to attach to that email. and also kind of that information about how they should go through the assessment, how they should collect the data. So please review that template, adjust it as you see fit, but use that to send it out to your hospitals. And like I said, include that PDF that has all of the questions so that they can review that and collect all the data with their team before going online to fill the assessment out. And the instructions, if they have any questions, this is similar to instructions for the NHSN survey. You know, it gives detailed instructions for how to answer each of the questions on the assessment. If your hospitals want more information, there are a lot of resources that we've developed, and those are available on the TASC website. So please take a look and send them there. There's a fact sheet just for critical access hospitals on there that has overview, some background information, a little bit of information on, you know, how this will benefit hospitals. And there's also a recording that is not as detailed as this information today, but has a lot of information about what is going on with the assessment and what it might look like, what it includes. So sending the assessment, you've received that template email that you can use to reach out to your hospitals. You should attach that PDF of the assessment questions and instructions to the email. And we ask that you send out your first email by the beginning of November, so within the next week. As far as tracking, this is something that we will be doing and sharing with all of you in early November. You'll receive a link to a Google Sheet that will have tracking and show you which of your hospitals have completed the assessment. On your state's tab, so all of the states will have a different tab. There'll be a row for each hospital that has completed the assessment. It'll have their name and their CCN, just so we have that duly covered, as well as the date that they completed the assessment. This is populated directly from the assessment itself, and so it's automatically updated, so it should be effectively real time. So once you have that link, you can go on and check at any point that you wish. We will be sending out periodic reminders throughout the assessment period, encouraging you to follow up with hospitals that haven't yet completed the assessment. But we just wanted to let you know that you'll be getting this information. You don't have to keep track in any way, just you'll be able to look at the spreadsheet and see what is happening in your state, who has filled it out. So this is just a very brief example of what that'll look like. So you'll be able to click on your state's tab, and then it will list the names and CCN, your state, and the date completed, so that you'll be able to see how things are moving. And like I said, the process for your hospitals, this is described in the email template that we sent to all of you. But after receiving the email from you all, hospitals should review the PDF questions and reference the provided detailed instructions if they have any concerns about how to answer the questions. They should work with their teams to gather the answers and then log on to the portal to submit their answers. We do recommend that hospitals submit their answers in one sitting. If they start to fill it out and then return to the same device to complete filling out the assessment, that should keep their answers. But we do recommend that folks do it in one sitting once they have gathered it. As far as the estimated time to complete this, the estimate based on our tests that were completed in the early summer by a couple of states that worked on our test was about 60 minutes to both gather and submit the data. This really does depend on the quality contact in a critical access hospital, on their experience, how long they've been there, their knowledge of their facility and their quality initiatives. So it does depend on a lot of things if they need to ask more or fewer people for assistance in answering the questions. In clicking through the assessment itself, it does not take 60 minutes to click through the assessment. The 60 minutes is the time anticipated to collect all of the information and then sit down at the computer. It can be clicked through pretty quickly if you have all the information in front of you. And so that's just something to keep in mind if you have hospitals asking you this information. After a hospital submits the assessment online, the CAH quality contact that they input as a part of answering questions in the assessment, that person will receive an email as confirmation, and that also includes the responses that they submitted. While they're submitting, as soon as you submit it, you're also able to download a copy of your responses there as well. But everyone that submits the assessment online will receive the responses submitted. And so this is something that they can refer back to and have, and will be able to reference in the future as well, so they won't have to start from zero or share with other folks at their facility. The deadline, the request is for all CAHs to complete the assessment by December 15th. You know, ideally, nobody wants to be working on this over the holidays. And so getting this completed by the 15th is wonderful, as well as we don't want state flex programs to have to be bothering their hospitals around the holidays either. And so that is the due date. And now I'm going to see if we have any questions immediately. Otherwise, I will pass it over to Laura at FORHP.
Megan, it's Lynette from Pennsylvania. Can you hear me okay?
Yes.
So I have a quick question, and forgive me for asking, but I printed everything off and I have it in this little binder, but I wanted to know, will there be an incentive? Because I did notice that there are 65 questions and I'm just so afraid that my hospitals are going to be like, not real enthusiastic about completing this in a timely manner. And I want to encourage them to complete it as soon as possible. Actually, I want Pennsylvania to be the first one to have all their CAHs submitted. So I'm going to work diligently on this.
Well, that, Lynette, is the perfect segue for what Laura was actually going to talk about. I think one thing I'll just note right off the top of the is that the CAH quality infrastructure component that Maddie walked through, again, that's based on the summit, that's based on those key elements of core elements of CAH quality infrastructure. That is on the list of new MBQIP measures. And so that is a measure. This is the only place they can submit that measure. And so that's a key piece of this discussion. But I'm going to hold on other questions for a second, and I will pass it off to Laura, who's going to talk a little bit about messaging. And I think that Lynette is a really great question.
Yeah, Lynette, I'm going to answer that question, but I know Jennifer Finley has her hand raised. Do you want to ask a quick question?
I do. Our hospitals are really excited about this survey. We've been talking about it for a while. So I know they're going to get busy, but I also know from past experience what it is like to manage 82 of them trying to fill something out. So we are probably going to tell them it's due before December 15th, because we always give a false deadline. So we have time to still push the stragglers. Do you have published anywhere that December 15th deadline? Because I don't want them to think I'm lying, but it's going to help me out if you don't contradict what I'm telling them. So unfortunately for that strategy, we do. Okay. So it is in a couple of places. So it is on that. It is on the CAH fact sheet, I believe, and it's on this information. And so all of this will be public. And so they may see it. But it's not like on the top of the survey itself. It's not on the assessment itself. It's if you can adjust the template that we sent along, if you want to put an earlier date on there, absolutely. Okay. Free to do that. But yeah, it's not on the assessment itself. Okay.
Jennifer, that is so smart.
Like I said, lots of years of doing this.
Okay, well, I'll go ahead and take it away really quick. If anybody has questions, jump on in, come off mute, etc. I'm going to make one note super quick before I get started on this messaging. I've had several of you private messaging me in the chat and sending emails that you did not get my email this morning with all of the information for this, and that includes the template for your email to your hospitals. So if you did not get this email, please let me know, let Megan know. I might go ahead and just resend it to everybody. If you get a duplicate, I'm sorry, but there's a lot of folks who didn't get it, and we want to make sure everyone has this information. So on this note, and there's a note in the chat from Mary about if this is mandatory or optional, I'll kick my remarks off there and kind of go into what's on this slide here after that on messaging to CAHs. So FORHP is asking that everybody do this, that all of the hospitals fill out this survey, right? We think there are a lot of things that we can learn from this survey, us at FORHP, you all at the state, all of your hospitals, et cetera. And we are very excited about it. As Megan mentioned, the quality infrastructure measure is part of our new MBQIP measures that are proposed to roll out. That is part of this assessment. So in order to complete submission for that measure, they would need to fill out the assessment. However, FORHP is not requiring the participation for this. It is strongly encouraged. We really do recommend that everyone fill this out, just like we do with all of the other core measures that are part of MBQIP. We see this overall as a step forward to getting more support towards your critical access hospitals on quality improvement activities, understanding the challenges that they have, not even just in quality improvement, but challenges in participating in MBQuip or participating in Flex. So we are happy to talk through with you anything on strategies to message to your hospitals. My biggest strategy that I would have, and these are some of the things that I put on this slide, is to just explain to them what the purpose of this is, right? Like, what are you at the state going to learn? What are your hospitals going to learn? And how are you going to use that information? So as Megan mentioned, I'm going to repeat a lot of things that Megan already said and that Dr. Dillon said when she kicked off this webinar. You can use this to orient your new staff at the hospital, all of your quality directors. I know so many of you come and tell us that you have so much turnover at all of the hospitals, and it feels like all you're doing is just saying the same things to people over and over and over again. Here is a great reference document that you can have and have all of those resources ready to go to tell people when they come in where they currently are. As Megan mentioned, we love collaboration at FORHP. I think you all know this, but this doesn't have to be a one size fits all collaboration, right? You can have cohorts of hospitals that are within your state. You can have cohorts across states. You can learn from other state flex programs, but it could be based on many different things, right? You want to learn to see how somebody else is doing something with swing beds, right? So hospitals in your state can do that. It can be rural health clinics. It can be people who all have maternity care. Like Megan mentioned, if you have the same EHR vendor, and especially if you've got several hospitals that have the same EHR vendor, and maybe they aren't figuring out how to pull reports out of it, how to pull data out of it, and you can kind of help guide them do that. I think we all kind of learned this when we came out with the quality improvement projects a couple years ago, of if you go and give your hospitals a question, you know, what do you want to work on if we have this quality improvement project? A lot of people said, we don't know, let me go talk to the hospitals. And they said, oh, 9 of them wanted to work in falls prevention. Okay, well, this can help you figure that out too. So all of what we're trying to do is just give you the tools to really give more targeted TA. Now that's you at the Flex program. It's also your contractors, helping them figure out what their needs are, what opportunities for improvement. We've been talking a lot at FORHP about really our move on Flex to go towards outcomes and showing the impact of the program. And a lot of that comes from you as your state Flex program working directly with your subcontractors, whether it's your quality contractor, your finance contractor, whoever, and writing in your contracts, I want this piece of information. I need this piece of data for you to help work in this and improve this measure. So having this assessment and tell you, this is exactly what we need to collect, you can work directly with your contractors, and then you two can be a team and work with your hospitals to really support them and move forward. And we've been saying this a lot, and especially as we think about the upcoming NOFO, all parts of Flex can be impacted by quality, right? Your quality affects your finance, your quality affects your population health, all those things. So you can kind of learn, especially if we're talking about service lines and who's doing what. Are these service lines in danger of closure? Are they not? This can really help give some information on how you may want to take the next cycle of your program. And I know Megan mentioned, you know, the timelines on things of getting the data back to you. I know that our NOFO is due, the applications are all due in mid-March, but if you get some more information in April, May, June, et cetera, we have never said to you at FORHP that you can't make a change in your work plan, right? So if you get some more information, you can say, I thought I wanted to do this project. I learned from our quality assessment, we actually need to work in something different. We are happy to work with you to figure all of that out. So I think that's all of my points there, Megan. I think our next bit is a little discussion, right? Or questions, maybe.
Yes, we can start with questions. I think we can start with general questions, or, you know, at the same time, if there's anything else that would be helpful to support the process that we're all embarking on today. Yeah, I see Liz.
So I just wanted to bring up that we're doing a data analytics project with one-time funding from the CDC to help the hospital pull their data from their electronic health records and break down their data silos. So this really ties into that quite a bit. Of course, getting the hospital buy-in has been interesting. But if anybody wants information about that and what we're doing, I can put my contact info in the chat.
Absolutely, that's great. Thanks, Liz. I see Emma.
Hi. So the survey closes on the 15th. And let's say one of my 77 hospitals isn't so into filling it out right away, but then they see that projects come out of it and they decide that they want to fill it out later. is there a way for them to complete the initial assessment in January, or is once it closes and it's a done deal and then they're out without that like initial baseline?
So I think right now, and part of the reason we call this as a pilot is because this is our first time. And so right now the plan is for this to be a deadline. So the plan is that this is something that we ask them to fill out by this time, like other, and getting back to the fact that the infrastructure measure is a part of this. Other measures have deadlines, and if you don't meet the CMS deadline, CMS isn't going to say, oh, sure, you can fill that out if you
Yeah.
So that's the plan right now. I think, it remains to be seen, is there some component of it that's rolling? Is there something we can do? Sure. But for this, at least for the pilot right now, this is a deadline that is pretty hard. And we're going to, the goal is to get as many folks in by December 15th. If there happen to be a few that want to fill it out later in December, that's a question, but after the holidays, we're closing it and we're going to start analyzing the data so we can get the data. If it's rolling, it's a lot harder to have national data in reports if it's still rolling. And so right now it's a deadline, but I think, like we said, we're going to be looking, and there was a question in the chat about, is this an annual assessment? I think ideally, again, the idea is that at least components of this would be annual, like the measure. But as we're doing this the first time, we're going to learn a lot, and we're going to see a lot of things, and we're going to ask for a lot of feedback from all of you. And so I think what the next iteration or iterations look like, and kind of what the timelines look like too, are up for discussion. But at this point, it is a deadline.
That's good. Thanks.
Thanks, Emma. Stacy.
Hello, can you hear me?
Yes.
Okay, I just wanted to just make a couple of just quick comments about this. I'm super excited for it, actually. I was on the planning committee for this, and Oregon was one of the states that went through the pilot assessment back in June. So I just wanted to let everybody know, at least from our experience, how that went. We sent the assessment out to all of the critical access hospitals here in Oregon. We probably had roughly a 50% response rate from it. And I've talked to a lot of the critical access hospitals since then, and it was really no big deal. I've heard, when we were in Kansas City at the CAH conference, there was questions, are the hospitals going to have a fit over having to do this assessment? It takes so long. It looks really long, but if you look at it, the questions are all multiple choice. So it really looks worse than really what it is. But the hospitals that completed it in Oregon said really not that big of a deal. The only comment that I got back was from one hospital that said it actually took them 2 hours versus the 1 hour to complete the assessment. And looking at that hospital, they have fairly new quality and a lot of new leadership at their hospital. So they really had to sit down, and if they wanted to answer accurately, it was probably a really good opportunity for them to sit down and go over the questions, because they learned a lot about their own quality program. But anyways, I also see a lot of benefits with this, not only for flex quality work, but, we're going to learn if hospitals have strategic plans and that type of stuff that can fall under your finance and operations work. And in Oregon, we offer a pooled option for our SHIP grant. And so I can see getting this data back and perhaps identifying areas where we can even leverage the information in our SHIP work that we do too. And our quality network that we have here in Oregon, a lot of those hospitals were the ones that participated in the pilot. And they keep asking, are we going to get a report? We want to see a report, because they're just thirsty for the information, because they want to learn from what other facilities are doing or who they can connect with in our state. So I see a lot of positives about it. And yeah, there will probably be some kinks to work out for the next year and moving forward. But I think that this is going to be a really great thing. Just wanted to say that.
Thanks, Stacy. We've got John has a hand up.
Yeah, thanks. I just wanted to, this is a question for Stacy or maybe some others who have thoughts on this. I've heard a lot of reasons why this is good for nationally and why it's good at the state level for our programs. But when we're selling this, we're going to need to have reasons why it's good for the hospitals, why they would want to do this. And so I'd just love to hear some some reasons, like when I'm talking to a hospital, what should I tell them? Oh, you should take this hour or two to do this because.
For Oregon, I can say we have our Oregon CAH quality network that brings all of our critical access hospitals together once a month and then also quarterly or throughout the year in person. And they essentially are wanting to, it's peer-to-peer sharing and networking. So, they are the ones, like I mentioned, that we're asking, are we going to get access to this report? We want to see what the information is that's coming back from it. The benchmarking piece of it is a big piece to them that they want to see, and also the service lines and what other hospitals across the state are doing. So from Oregon, I think that that's one of the areas that I would highlight.
Okay, so we can get partners that are interested in this. I'm thinking like our State Hospital Association Quality Network might be interested in this. So that's one reason. Anything else?
Hey, yeah, this is Jennifer in Kansas. We have had in the past year a couple of questions come up related to EHRs in specific. Like we're trying to figure out how to build this in our EHR, or we're trying to figure out how to pull this data out, but we don't have a way without just sending out random emails to match them up with hospitals that have similar systems so that they can work together. Because most likely somebody's figured this problem out, but we have a hard time connecting them. So that's one example. And then we had somebody who was wanting to start a new service line and was looking for another hospital who had that service line. And again, it was newer. We didn't really know who to partner them up. And they even wanted to talk to out-of-state folks. So I can see a lot of opportunities for helping each other with really specific needs that we aren't able to do right now because we don't have that information.
Yeah,
and then, hi, yep, same for North Dakota is what Stacy had mentioned too with the CAH Quality Network here in North Dakota. We too were part of the pilot, and when the data came back, some of the data was a few things that was very informative. Other pieces we thought, yep, that was right on, things that we were thinking of. But as a CAH Quality Network, we're able to have more informed conversations, exactly what they're talking about. Across the board, who's using Epic is always, they're talking with one another and doing those builds, about being able to, when you transfer from point A to point B, that's going to be super helpful. We knew we had some problems about behavioral health situations, and we have a new high value network developing in the state. So procedures, surgeries, things like that are happening. Where were some of the lower topics around that? That was showing up in the data. So this is really going to be informative for us. So we didn't get, high percent, but I'm glad to know the numbers, glad to know that I'm able to have real-time data about who's reporting on the assessment and who's not. That's going to help me target my my work on my end of who I need to reach out to. So I appreciate that. That's often how I operate for the EDTC measures. So I'm able to kind of treat it like already one of the MB-QIP measures. So I think this will be doable for us. Yeah.
Thanks, Jen.
I just wanted to share from my immediate past experience in Montana, a couple of the things that we saw right away that were benefits directly for the critical access hospitals is that by completing this assessment, I actually this summer had hospitals specifically ask, is there anything that I can take to my board or to my leadership to validate the work I'm doing and what a good quality program looks like? And it was really exciting to say, yes, literally, we have that thing in a couple months. And so that helps build maturing quality programs in critical access hospitals. And with the inventory, that measure inventory piece, we were already doing that in Montana as hospitals were like, we need help with our departments identifying different quality metrics for our QAPI programs. And so we were able to compile some of that so hospitals could connect and look at and support their staff also. So those are two very big benefits, I think, that go directly to the CAH itself.
And so for those of you saying that hospitals are able to find each other, I'm assuming that they do that through the State Office of Rural Health, the Flex program, because we have the full data. They're not going to get a statewide report. Is that correct?
Correct. So the individualized data will go to the state flex programs. They will be able to see a state report compared to national, but it'll be in working with the state flex program. So they will be working with you, which is a benefit because they need you. But also, yeah. And so just to kind of add on what others folks have said, it's that infrastructure measure, like Jen was saying, it's saying, wow, you'll really have a good comparison of what does that quality infrastructure look. This is a first, this measure is new, it's been created, but they have a way to show, how well are they doing in their hospital with CAH quality infrastructure, and then what does that look like compared to the rest of the CAHs across the country or in our state. And then it's really, for the state flex programs are going to be able to tailor that funding to hospitals. What are hospitals' greatest needs based on some of that infrastructure work? So hospitals can anticipate that state flex programs can be more responsive to what they might need, what they might be able to do. And then it really is that pairing, that pairing of hospitals with other hospitals that are either like them with EHRs or service lines, or unlike them. They have successes in areas where some others are challenging, or they have service lines that others want to adapt. And that's within your state or between states, and really just being able to make those connections and help them get some of that assistance. And it can be all sorts of those different components. It can be that they have this service line and the same EHR and they're not part of a system, right? So it's really combining all of those different components that are going to be in the data to be able to say you can really get it very specific as to how you want to make your cohorts or how you want to best support your hospitals.
Awesome. Thanks, everyone.
Yeah, thanks, John. Other questions about logistics, about the assessment, or anything else that would be helpful in support? We really tried to have a lot of those supporting documents right away, but we are always happy to create other things or provide you with other information if something else comes up.
There is a question in the chat from Jennifer. Did you unmute to say it?
I did.
Okay, go for it.
So we have 4 hospitals in various stages of converting from PPS to CAH. Do we want them to go ahead and complete the survey? I mean, I'd love to have this information about them, but I don't want to screw you up because they're not technically part of our 82 critical access hospitals today.
Yeah, I mean, I don't have a problem with getting that information for. I think that's.
I don't either.
Yeah,
okay.
No, I'd say if you know, we can always pull them out manually if later, if something, if you want them excluded or whatever, we could be in conversations on that. But yeah, absolutely. And that goes, I know there are other states that have a few as well, kind of in the works. And so if you know of someone, feel free to send it more broadly. If you want to send us a note as far as, why are we getting this hospital? Feel free to send us a note too. But yeah, absolutely. Send those along and we can, it should just populate. We don't have a master list in there of anyone that shouldn't be doing it. So they should be able to have no problem actually going in and filling it out.
I think when it comes to anybody there was a question maybe in the chat about whether or not a hospital who's considering a conversion to an REH should be filling out this survey. And I would say it might be kind of the state's discretion on how much you want to push them to do it on, like, have they already filed their application to convert to an REH and we think it's going to get approved and it's going to be approved with like next month? Then probably not. Are they still having the conversations and they're more curious rather than serious and they don't know if they're going to convert to an REH yet? Then they probably should fill this out because maybe that would help them make the decision and say, you know what, yes, we really do need to convert to REH, or no, we don't. So that answer might be an it depends when it comes to REHs.
Absolutely.
Laura, I had a question too that someone sent me about disseminating that sample letter that you sent to all the state flex programs. They were curious if they could send it out to all their CAHs in one general email.
Yep, somebody asked me that question earlier today too. And that answer is yes, you can send it out however you see fit. If you want to send out a blanket email, go for it. If you all know your hospital's best, right? More than we do. There are sometimes you can use my strategies, right? There are sometimes when I send out an email to all of the flex programs at once. There are other times I know I maybe need to tailor the language a little bit to like these states or whatever. So I think your hospital's best and you can send it out however you would see fit.
Another clarifying question. I know that when they fill out the survey, I saw they automatically get a copy back as a result. Are they going to get any kind of a report like they get for antibiotic stewardship that shows their performance compared to others?
So initially in this, again, this first round, the data will go to the states. There will not be individual reports, but because the CAH quality infrastructure measure is a component of this, that eventually will be in your MBQIP reports.
Okay.
So it won't be initial. I mean, it'll take some, we're in the process with all of the new MBQIP measures of adding those to the MBQIP reports and adjusting those. So that isn't imminent, and it won't be right away when you get the data from the assessment, but in the longer term, they will get that CAH quality infrastructure component of the assessment in MBQIP reports. So they will get that individualized data compared to your state, compared to the national as well.
And I'm assuming you wouldn't care if we created our own little report to send them based on the data you give us.
Absolutely. Yep. And part of that tool that we're creating with the spreadsheet, we'll be doing some of that to show you, you can look hospital by hospital. How is each hospital doing on those? And so that will help you to look at it, not just a spreadsheet, but more in like a table that shows you all of those different things. And so definitely check out the tool and how that works too, to see how you want to do it. But absolutely feel free to, that data is yours to do absolutely anything creative that you want, but eventually that data will be in MBQIP reports from that assessment or from the infrastructure component.
And Melissa just asked a really great question in the chat. Which person at the hospital is everybody planning on sending that email to? Is it the whole C-suite, your quality director, somebody else? Does anybody want to chime in with some thoughts?
And I'll just say in theory, this was tailored so that a quality director or, the quality contact at the hospital was the ideal audience, but we recognize, and why we say they should be talking to other people, is there are some questions that they're not going to know the answer to. They may not know the volume answers. They may not know some of the other components. And so it was tailored toward quality folks because we are really focusing on the quality aspect, and, the reporting pieces, that's something that they're the ones likely to know. But I think it's up to all of you, where you send, if you send it to quality and CEOs or, whatever. But I think just so you know, it's tailored towards quality folks. But if folks have ideas on how they're going to disseminate, we'd love to share.
Well, Jen in the chat wrote quality folks and the CEOs. Tell them that they're both getting it, but that they only need one response.
Yes, perfect.
That's helpful. Thank you.
No problem.
And there's another question in the chat about the word required.
I saw that too.
Laura, that one's yours.
Yeah, I think Robin worded it perfectly on, it's kind of up to you on how you want to play with that word required.
Yes.
So Laura, it's Lynette from Pennsylvania. Yes. And Megan. So this is what I usually say. And I guess I should, I say to our hospitals that it's required for if you want to receive federal funding. Should I not be saying that? They're like, well, if you want to get funding, it's kind of required. I don't say kind of, just say it's required, because if you tell them it's optional, they're not going to do it.
Well, I think some of this kind of depends on how you at the state want to run things. And the best example that I'll give is back during COVID. Remember when we suspended, the MBQIP requirements, we suspended reporting, right? But I know several states came and told me, they said, I know that you all suspended this at the federal level. I did not tell my hospitals that. I told them all that it was still required because I know when the time comes that we, are ramping all of this back up again, that it's going to be, twice as hard, 3 times as hard to get them to report again. So how you say this to your hospitals, I am leaving that up to you. Like I mentioned before, the same as the MBQIP measures, all those things, like this is not required in the sense that I'm going to take away Pennsylvania's funding if you don't do this assessment, right? I'm not going to do that. I don't have the power to do that. But it is strongly encouraged. And we know all of the information that we're going to gain from this and what you will gain from this, but it will be part of, well, it's all a part of the new proposal for the MBQIP measures. And so they all kind of go hand in hand, which I know is a wordy, word vomity answer, but did that make sense?
Yes. And I like what Danielle just put in the chat.
Yep. Yeah, she put to continue to benefit from federal funding through flex, it's required, right? So it's
Yeah,
how.
so that's
it's
what
in
I'm
the
gonna
form.
say. Thank you for that.
Right, and I know we've already wandered into the last two bullets on this page too. Any ideas for how to encourage your hospitals to participate? And that's, from the verbiage to how you reach out to all of those different pieces. And then ideas for how you as a state flex program will use the data. We've touched on that, but if others have any thoughts or questions for others, we have some time, but we want to make sure we answer any questions that you all have for a minute.
So it's Lynette again. Everyone's gonna get mad at me because I just.
No one is mad at you, I promise.
So how I'm gonna encourage our cause to complete it in a timely manner is I'm gonna tell them that I strongly encourage you to do this to benefit from the flex funding. However, I would like everyone to do this as soon as possible to be in competition with the rest of the states. And I think this data is going to be really, really instrumental when we're filling out the PIMS report in the future. This is going to be really helpful. I mean, data is everything. So it tells the story. So, all right, I'm done talking.
You can always talk, Lynette. We love to hear from you.
So I know I said I was not going to say anything, but I just had an idea. Would it be possible if we could regroup in 2 weeks to see how it's going and to see if there are any challenges or concerns that anyone else may be having that they could share how they implemented it or corrected that challenge? I mean, just for me, I think that would be beneficial.
Yeah, maybe something like an open office hours. If you
Yes,
want to come,
yes,
you can.
that
If
would
you
be
don't have any
great.
concerns, you're fine.
Yeah.
I think we can. I think we can set that up. And I know Caroline's on the call. I bet we can work with her to find a date and put a Zoom link together.
Great. All right. Thanks. I'm done.
And I think the biggest thing is, folks are going to have questions. You can send them, you can send hospitals directly to me if you all don't have the answers or don't want to answer the questions. And you can ask if any state flex programs have questions. You can ask your project officer or me. We're going to be in direct communication with each other. And so if you have questions and it goes to the wrong person, it's not a big deal. But
we always, what is it that Caleb says? There's no wrong door.
Yes.
All the time.
Yes, exactly. Thank you, Caroline. And so, yeah, there's lots of here. We have another slide, I'm sure. Just in thinking, we're really excited about this, all around, and it's going to be so critical to helping support the flex program in your states and nationally. And it really just, depends on the participation and the folks getting in that information. And we are more than willing to help if you have questions or need a different resource or different ways of saying things. We're happy to help you work through those too. Let's see. Another question. There we go. I like that. Required, no. Necessary, yes. I love it.
I'm going to tell my hospitals in Texas we've been challenged by Lynette and we need to step it up.
I like that excitement. Eva, you've got a little bit of a higher task than Lynette, but hey, I like that. I like that willingness to go for it.
Yeah, Eva, you have slightly more hospitals than Pennsylvania.
just a couple here and there,
A lot more.
Yeah, they'll be excited to say, oh,
yeah.
We've been challenged. Yes. We don't, us down here in Texas don't like to be challenged. So we'll take the challenge, I guess. I hope I'm going to tell them they can't make me look bad now because I said we were going to do this.
Right. You put it up. I love it. Laura, anything else from you?
I don't think so. Just reach out if you have any questions, and I'll just go ahead and I'll make an executive decision and I will resend the email so for the folks who didn't get it. Maybe check your spam folders just in case it went there, but I'll resend the email so everybody has it.
Hey Laura, this is Nicole at TASC. I did post a link in the chat. It's up a little ways now. That has a direct link to the template on our website. I know that we're going to have a discussion about the email list here in a few minutes, so that might be quicker to just know that template is on our website.
Perfect.
That last link that was just posted in the chat, yeah, those two links are it.
Perfect.
Either one of them will get you there.
Thank you, Nicole.
Yep.
All right. Well, thank you, everyone. We're really excited to start seeing all of those assessments come pouring in the next couple of weeks. But let us know if you have any questions. Thank you all
Thanks,
so much.
everyone. Thank you, everyone.